Welcome to the deep dive. Looks like we're going deep into baby cardiology today. Someone sent us a bunch of notes and medical excerpts all about acyanotic heart conditions in newborns.
Oh, it's a fascinating area.
Yeah, for sure. So for our listeners out there who might not be cardiology experts, can we start with a quick explanation of what acyanotic actually means?
Absolutely. It basically means these babies have normal oxygen saturation.
Okay, so their skin color looks normal.
Exactly. They don't have that bluish tint you see in babies with cyanotic heart conditions.
No blue babies here. But we are dealing with some complex stuff.
We are.
PDA, ASD, VSD, even CAVC, and some valve issues are in the mix.
All on the list.
Okay, so our mission for this deep dive is to unpack all of that.
Exactly.
What each condition means, what signs to look for, and what the treatment options are.
That's the plan.
Sounds good to me. Now, I noticed one term that kept popping up in the source material, left-to-right shunting.
Ah, yes.
Can you give us a crash course on what that means?
Sure. So think of the heart as two pumps working side by side. The left side is the powerful one.
Pumping the blood to the body.
Exactly. And the right side pumps blood to the lung to pick up oxygen.
Okay, so it's a beautiful organized system.
It is, but with left-to-right shunting, there's a detour.
Oh,
Blood flows from the left side of the heart, where the pressure's higher,
okay.
over to the right side.
So instead of going to the body, some blood sneaks back toward the lungs.
You got it. And that extra blood in the lungs can cause all sorts of problems.
Like what?
It's like a traffic jam in the pulmonary circulation.
Oh, okay.
It puts a strain on the heart, and it can lead to long-term complications if it's not addressed.
Makes sense. Now let's talk about a specific condition where we see this shunting. Patent ductus arteriosus, or PDA.
PDA, yep.
Some people call this a hole in the heart.
It is, it is.
Is that an accurate way to describe it?
It is. You see, the ductus arteriosus is this blood vessel that's vital during fetal development.
Okay.
Since the fetus gets its oxygen from mom, this vessel bypasses the lungs.
Makes sense.
But after birth...
It's got to close.
Exactly.
So with PDA, it doesn't get the memo.
Exactly. It stays open.
And what happens?
It creates a shunt, a pathway between the aorta...
The main artery.
Right, the one sending blood to the body, and the pulmonary artery, which goes to the lungs.
So some of that freshly oxygenated blood is taking a U-turn back to the lungs.
Yep, that's exactly it.
That can't be good.
No, it's not ideal. This extra blood flow to the lungs can cause a bunch of problems.
Oh,
Rapid breathing, fast heart rate, even a heart murmur.
okay.
And in severe cases, you can even see fluid buildup in the lungs.
That sounds serious.
It can be.
What can be done about it?
Luckily, there are a few options. Sometimes the PDA closes on its own.
Really? On its own?
Yeah, especially in premature babies. We can also use medications to encourage closure.
Now, I read that sometimes prostaglandins are used for PDA.
Uh-huh.
Isn't that kind of counterintuitive? I thought those were sometimes used to keep the ductus open.
You're right. It might seem strange, but sometimes we do need to keep it open.
Why?
If there's another heart defect present
Okay.
that relies on the PDA for blood flow, we need to make sure that stays open.
So it's not as simple as just close the hole.
Nope, it's definitely not a one-size-fits-all situation.
So what happens if those options don't work? The meds are closing on its own.
If those don't work, we often recommend surgery, especially for larger PDAs.
And what's the prognosis like for babies with PDA?
The good news is that whether it's meds or surgery, PDA closure usually has really excellent outcomes.
And that's reassuring. Okay, let's move on to another hole in the heart condition, atrial septal defect, or ASD.
All right, ASD.
So where's this hole?
This time, the hole is between the atria.
The top changers of the heart.
Exactly. Normally, blood flows from the right atrium to the right ventricle, to the lungs to get oxygenated,
Right.
then back to the left atrium, left ventricle, and out to the body.
Quite a journey.
It is, but with an ASD, there's a disruption in that flow.
Oh, how so?
Blood can flow directly from the left atrium to the right atrium because of the pressure difference.
So it's like skipping a step.
You could say that, and you might think, hey, a shortcut, less work for the heart.
Right.
But it's not that simple. A large ASD can actually force the right ventricle to work harder.
Oh, so it backfires.
It does, and this can lead to thickening of the heart muscle over time.
That doesn't sound good. What are the long-term implications of that?
Well, the right ventricle can get tired from working so hard. That can lead to pulmonary vascular disease,
Which is?
where the blood vessels in the lungs become damaged. Think of it like trying to force a lot of water through a narrow pipe.
Eventually the pipe bursts.
Exactly. It wears down. So even though these babies look healthy at first, there can be some serious consequences down the line.
So what are some signs that a baby might have an ASD?
You might hear a heart murmur or feel a strong pulsation on their chest wall. Diagnostically, we use echocardiograms.
Which is basically a sonogram of the heart, right?
Exactly, and chest x-rays.
So what about treatment? Is it similar to PDA?
The good news is that Small ASDs often close on their own.
Really?
Yep, especially in the first couple years of life. But for larger ASDs, surgery might be necessary.
And what are the long-term outcomes like for ASDs?
Just like with PDA, generally excellent.
Okay, that's good to hear. So we've talked about holes in the atria. What about the ventricles? That's where VSD comes in,
You
right?
got it, ventricular septal defect.
VSD. And I read that this is actually the most common of these defects.
You're right, it's a hole in the wall separating the ventricles, the lower chambers of the heart.
Okay, so another hole. And I imagine these can vary in size.
Oh, absolutely. They can be tiny, like a pinprick, or quite large.
So some are minor and some are much more serious. Does the size of the hole determine how serious it is?
It definitely plays a role. Small VSDs, especially in a certain part of the ventricular wall, have a good chance of closing up on their own within the first 2 years of life. But larger, unrestricted VSDs, those are the ones we worry about.
Right.
Those can lead to some pretty significant problems.
Like
Well, remember those pressure differences we talked about?
between the left and right sides of the heart?
Exactly. With a large VSD, the pressure in the left ventricle, which is much higher,
Right.
it equalizes with the pressure in the right ventricle. This means a huge amount of blood gets forced into the pulmonary artery.
So too much blood flow to the lungs again.
Yep. And all those consequences we talked about, pulmonary edema, where fluid builds up in the lungs, and congestive heart failure, where the heart struggles to pump effectively,
Right.
those are all possibilities with a large VSD.
Wow, so these babies might look healthy, but they could be silently struggling.
That's the thing about these acyanotic conditions. They can be sneaky.
So how do we help these babies?
Well, it depends on the size of the VSD and how much it's affecting the baby.
Okay.
For small VSDs, we might just watch and wait.
To see if it closes on its own?
Exactly. But for those larger ones, especially those causing symptoms, medications can help manage heart failure.
And what about surgery? Is that ever on the table for VSD?
Absolutely. If medications aren't enough, or if the VSD is very large and causing serious problems, surgery is often the best option.
So the goal is to prevent that long-term damage to the lungs and make sure the heart can function as it should.
That's the goal.
Okay, so we've covered PDA, ASD, and VSD, three different types of holes in the heart.
Right. Different locations, different implications.
Exactly. Now, I know there's another one, complete atrioventricular canal, or CAVC. That sounds particularly complex.
It is more complex. It's kind of like a combination of ASD and VSD.
A combo?
Yeah. It involves a hole in the wall separating both the atria and the ventricles.
So both upper and lower chambers.
Yep. And you also see problems with the valves controlling blood flow between those chambers.
So it's like a double whammy for the heart.
Exactly. CAVC is most often seen in babies with Down syndrome.
Oh, really?
Yeah. And it can lead to a whole bunch of problems.
Like,
Heart failure, excess blood flow to the lungs, and even irreversible pulmonary hypertension in severe cases.
that sounds incredibly challenging.
It can be.
What are the treatment options for CAVC?
Well, milder cases can sometimes be managed with medications to help the heart pump better and improve breathing.
Okay.
But for a complete CAVC, surgery is typically necessary.
And I imagine this is a pretty complex surgery.
It is. It's a big surgery, and recovery can be tough. These babies often need to stay on a ventilator for a while.
So it's a long road for these families.
It is, and it's important to remember that these babies often have other health concerns related to Down syndrome
Right.
that can complicate things, like breathing difficulties due to an enlarged tongue or low muscle tone.
It sounds like managing CAVC requires a really skilled team.
Oh, absolutely. It's a multidisciplinary approach.
Okay, so we've talked about holes in the heart, but what about valve issues?
Ah, the valves. They're like the gatekeepers of the heart, making sure blood flows in the right direction.
Hmm.
Problems can occur in the valves controlling blood flow out of the heart,
Okay,
or in the valves between the atria and the ventricles.
and these can cause all sorts of trouble.
They can, but the common thread is that they often overload the heart with too much blood.
Overload, like it's being flooded.
That's a great way to put it. And just like with the shunts, this extra volume puts a strain on the heart muscle.
So what needs to be done?
Most valve problems need surgery to restore normal blood flow.
And are there different types of valve problems?
Yes, there are. The two main types are stenosis, which is a narrowing of the valve.
Like a doorway that's too small?
Exactly. And then there's atresia, where the valve is completely closed.
Like a door that slams shut?
Yep, and both of those disrupt blood flow and lead to pressure buildup in the heart.
So it's like a plumbing problem, but with the heart.
You got it.
And this can happen in any of the heart valves,
It can. For example, you could have a narrowed aortic valve.
which controls blood flow from the left ventricle to the body.
Exactly, and that can restrict blood flow to the whole body. Or you could have a pulmonary valve that's completely closed.
Which controls blood flow to the lungs.
Right, and that means the lungs won't receive enough blood to be oxygenated.
It sounds like valve issues could be pretty serious.
They can be, which is why early detection and treatment are so important.
Makes sense. Okay, we've covered a lot of ground here. Let's shift gears a bit and focus on a specific area of the heart. The left ventricular outflow tract, or LVOT.
LVOT.
Why is this area so important?
Well, think of the LVOT as the exit ramp from the left ventricle,
Okay,
the heart's main pumping chamber. Any obstruction in this pathway can really mess things up.
like a traffic jam on the highway.
Exactly. And these blockages can cause all sorts of issues. Even before birth, impaired blood flow to the left side of the heart can lead to poor growth in the womb.
So these babies can be affected even before they're born,
Oh, absolutely. And after birth, an obstructed LVOT can make it really hard for that left ventricle to pump effectively.
leading to
Pressure buildup, potentially heart failure.
what causes these obstructions in the LVOT?
There are a few possibilities: a narrowed aortic valve, a thickened heart muscle, even an abnormally shaped aorta.
It sounds like a lot can go wrong.
It can, and it's often linked with VSD.
Right, that hole in the septum.
Exactly, and that just makes things even more complicated.
And I imagine aortic arch hypoplasia, where the aorta is underdeveloped, can also cause problems in the LVOT.
Absolutely. That can make the aorta narrower than it should be, further restricting blood flow.
It seems like all these different conditions can have a domino effect on each other.
They can, and understanding those connections is really key to recognizing and treating these complex cases.
Okay, let's dive into a specific type of LVOT obstruction. Aortic stenosis.
Aortic stenosis, all right.
What's happening in this condition?
So aortic stenosis, or AS, is a narrowing of the aortic valve.
Which, again, controls blood flow from the left ventricle to the aorta.
Yep. And this narrowing can occur at the valve itself, below the valve, or above the valve.
So there are different variations.
There are, and this restriction can cause all sorts of trouble.
Like,
Well, the biggest concern is that the body isn't getting enough blood flow,
okay,
which can impact growth and development. And over time, the left ventricle has to work harder to push blood through that narrowed valve.
so it gets tired.
Exactly. The muscle thickens, and eventually it weakens.
Kind of like trying to push a heavy object through a narrow doorway.
Perfect analogy. And the severity of AS can range from mild to life-threatening. Some babies are born with critical aortic stenosis.
Meaning,
The narrowing is so severe that they depend on the PDA to survive.
so in those cases, keeping the PDA open is actually a good thing.
Exactly. It's like a temporary detour that keeps blood flowing until we can intervene.
With surgery.
Exactly.
What about babies with less severe AS?
They might not show symptoms right away, but over time, that narrowing can lead to fatigue, shortness of breath, chest pain, even fainting.
So early diagnosis is crucial to prevent those complications.
It is. Ideally, we need to identify these babies before they're born.
Is that possible?
It is, with fetal echocardiograms, or at least immediately after birth.
So how is AS diagnosed?
We use a combination of things: echocardiograms to visualize the heart, chest x-rays to see if the heart's enlarged,
Okay.
or if there's fluid buildup in the lungs.
And what are the treatment options?
For critical AS, we often use prostaglandins to keep that PDA open.
Right, to keep the blood flowing.
Right. Until we can perform surgery, we might also need to use a ventilator to help them breathe.
And what about the surgery itself?
The most common procedure is called an aortic balloon valvotomy.
What's that?
We insert a thin tube with a balloon on the end into a blood vessel
Okay.
and guide it to the narrowed valve. Then we inflate the balloon to widen the opening.
Wow, that's incredible. But I imagine it's not just a one-time fix.
You're right, it's not. Even after surgery, these babies need a lot of attention. We need to carefully manage their blood pressure,
To prevent.
damage to the repaired valve.
So it's an ongoing process.
It is. These babies need long-term follow-up and careful management.
Okay, we've covered a lot of ground with aortic stenosis. Let's move on to our last condition for this part of the deep dive. Coarctation of the aorta.
Coarctation, okay.
What could you tell us about this one?
Imagine the aorta is like a highway for blood.
Carrying oxygen-rich blood from the heart to the rest of the body,
Exactly. Now imagine a bottleneck somewhere along that highway.
restricting traffic flow.
That's essentially what's happening in coarctation of the aorta.
So instead of smooth sailing, blood flow hits a major roadblock.
Yep. Coarctation is a severe narrowing of the aorta, usually near the ductus arteriosus.
Okay.
This narrowing blocks blood flow to the lower body,
Oh, wow.
and it makes the left ventricle work overtime to push blood through.
Just like we've seen with these other conditions, that extra work can really damage the heart, right?
Right. Over time, it can lead to thickening of the heart muscle and weaken the heart's pumping ability.
What are some signs that a baby might have coarctation of the aorta?
It can be tricky because the presentation can vary a lot.
Meaning,
Some babies have no signs at all.
really? No signs?
None. while others might have high blood pressure in their arms, but weak or absent pulses in their legs.
Oh, wow. That's a pretty stark difference.
It is, and then in severe cases, you can see babies go into cardiogenic shock,
Which is,
where the heart basically can't pump enough blood to meet the body's needs.
that sounds like a true medical emergency.
It is. Early diagnosis and treatment are absolutely crucial.
So how is coarctation diagnosed?
Echocardiograms are crucial, of course.
To visualize the narrowing.
Right. Chest x-rays can also help if the heart's enlarged or if there's fluid in the lungs. Sometimes we'll use other imaging too, like CT scans or MRIs, to get a more detailed picture.
So once it's diagnosed, what are the treatment options?
The first step is often prostaglandins, which can help keep the PDA open.
But I thought coarctation restricts blood flow. Why would we want to keep another pathway open?
It seems counterintuitive, but in this case, we need to make sure enough blood is getting to the body.
So it's about finding the right balance for each baby.
Exactly. We might also need to use a ventilator to help them breathe,
Okay.
and diuretics to remove excess fluid.
So what about surgical options?
The definitive treatment for coarctation is surgery to repair that narrowed section of the aorta.
Okay.
The type of surgery depends on the severity and the age of the child.
So some cases are more urgent than others.
Exactly. Less severe cases might be treated electively, while severe coarctation often requires urgent surgery.
What's involved in the surgery itself?
The most common approach is to remove the narrowed segment and sew the two ends back together.
Sounds pretty straightforward.
It sounds it, but it's a major surgery. Thankfully, though, surgical techniques have advanced so much.
That's good to hear.
The outcomes are generally excellent now.
That's reassuring. Any other interesting facts about coarctation?
One cool thing is that untreated coarctation can actually lead to the development of collateral arteries.
What does that mean?
It's like the body creates its own bypass system.
Wait, the body can reroute blood flow around the bottleneck?
It's incredible, right? The
Yeah.
body is amazingly adaptable.
Wow, so even in the face of this serious condition, the body finds a way.
It does. It's really remarkable.
So we've covered a lot of ground here, from left to right shunting to coarctation of the aorta.
We have.
It's amazing how all these acyanotic heart conditions we've discussed, while they're all different,
Right.
they all affect blood flow in different ways.
It all comes back to that delicate balance in the circulatory system.
Exactly, and they all highlight the importance of early detection and intervention.
Absolutely. That's key for ensuring the best possible outcomes for these babies.
It really makes you realize how intricate the heart is, especially in these tiny babies.
It's a marvel of engineering, for sure.
Well, we've covered a lot in this first part of our deep dive on acyanotic heart conditions.
We have.
And it's clear that we've only just scratched the surface.
There's so much more to explore.
We'll continue our journey in the next part of our deep dive.
Looking forward to it.
But before we go, what stands out to you the most from what we've discussed so far?
What's fascinating to me is that even though these babies might appear healthy,
On the outside.
exactly, these acyanotic conditions can be silently impacting their hearts and potentially their futures.
It's a crucial reminder that early detection is key.
Absolutely. The sooner we can identify and address these conditions, the better the chances for a long and healthy life.
Well said. Join us for part 2 as we continue to unpack this complex and fascinating topic.
See you then. It's amazing, isn't it?
What is?
Just how much our understanding of these acyanotic heart conditions has evolved.
Oh yeah, absolutely. I mean, it wasn't that long ago that many of these conditions were basically considered untreatable.
Right. It's incredible to think about how far we've come.
From those early days of open heart surgery with long and difficult recoveries,
Yeah.
to these minimally invasive procedures where babies can go home in a matter of days, it's remarkable.
It really is.
And it's not just the surgical side of things. I mean, the medications, the imaging technology.
The echocardiograms we talked about.
Exactly. And even genetic testing. It's all completely revolutionized the field.
It really has. Now we can often diagnose these conditions before a baby's even born.
Which is incredible.
It is. It allows us to intervene so much earlier, create these personalized treatment plans.
Speaking of personalized treatment, I'm curious about the role of fetal intervention.
Fetal intervention.
Yeah. Is it actually possible to treat some of these conditions before birth?
That's a great question. It's a really exciting area of research.
It is. It is.
There's huge potential there. While it's still pretty early, it does offer the possibility of correcting certain defects
Okay.
before they can cause any irreversible damage.
So instead of waiting until the baby's born to intervene,
Right.
we could potentially address the problem while they're still in the womb.
Exactly. It's a whole new way of thinking about how we approach congenital heart disease.
What are some examples of these fetal interventions?
Well, one example is balloon valvuloplasty,
Okay.
where a tiny balloon is inserted through the mother's abdomen.
Wow.
and guided into the fetus's heart to widen a narrowed valve.
That sounds like something out of a movie.
It's pretty incredible, and researchers are exploring other interventions too, like
Yeah.
placing stents to open up blocked vessels and even performing open heart surgery on the fetus.
Open heart surgery on a fetus.
I know, it's mind-boggling.
A heart the size of a grape.
It's amazing. It really shows how dedicated the medical community is to pushing those boundaries.
Of course, I imagine fetal intervention comes with its own set of risks and challenges.
Oh, absolutely. It's not a decision that's made lightly.
No, I wouldn't think so.
We have to carefully weigh the potential benefits against the risks.
For both the mother and the baby.
Exactly. And it's important to remember that fetal intervention isn't a magical cure-all.
Right.
Some babies might still need surgery or other interventions after they're born.
But it's still amazing to think that we can potentially give them a head start, even before they take their first breath.
It is. It's really a new frontier of hope for these families.
It's incredible how science is always moving forward.
It is.
What might seem impossible today could be routine tomorrow.
Exactly.
And I think that speaks to the critical role of research in this field.
Oh, research is absolutely essential. It's the engine driving all of this progress.
It's through research that we can gain a deeper understanding of these conditions, develop new treatments, and ultimately improve the lives of these children and families.
And research requires funding, collaboration, and a shared commitment to advancing knowledge.
Exactly. It's not just one person working in a lab.
It takes a village.
It really does. And speaking of the village, I think it's also important to acknowledge the role of advocacy groups and patient organizations.
Oh, they are absolutely essential.
They raise awareness, provide support to families,
Yeah.
and advocate for policies that improve access to care and research funding.
They are a powerful voice for those who might not otherwise be heard.
Now, shifting gears a bit, we talked earlier about how we can sometimes diagnose these conditions before birth.
Prenatally, yeah.
What are the tools that make that possible?
One of the most important tools is fetal echocardiography.
Which is,
It's basically an ultrasound specifically designed to evaluate the baby's heart.
while they're still in the womb.
Exactly. It gives us a sneak peek at those tiny hearts.
What kind of information can we get from a fetal echo?
We can see the structure of the heart in detail,
Okay.
assess blood flow patterns, identify any potential abnormalities.
That's amazing. Early detection must make a huge difference.
It does. It gives us the opportunity to plan ahead, assemble a specialized team,
Right.
be ready to provide the best possible care from the moment that baby's born.
Like having a game plan in place.
Exactly.
Now, we've talked about the medical and surgical aspects.
Right.
But what about the long-term management? What kind of follow-up care do these children need?
That's a really important aspect. Long-term management is all about ensuring optimal outcomes.
So regular checkups, I imagine.
Yes, absolutely. Regular checkups with a pediatric cardiologist.
To
Monitor their heart function, track their growth and development, make sure everything's progressing as it should.
So it's not just about fixing the immediate problem. It's about providing ongoing support,
Exactly. We need to be vigilant, watching for any signs of complications.
judging medications if needed.
And providing personalized advice on lifestyle modifications.
What kinds of lifestyle modifications are we talking about?
Well, it depends on the condition and the interventions.
Okay.
Some children might need to limit strenuous physical activity, avoid certain contact sports,
Makes sense.
or even take preventive antibiotics before dental procedures.
Preventive antibiotics. Why is that necessary?
Certain heart conditions, particularly those involving valve repairs or replacements,
Okay.
can increase the risk of endocarditis,
Which is?
an infection of the inner lining of the heart.
Oh, wow. That's serious.
Antibiotics help prevent that.
So it really is a team effort
It is
involving not just the cardiologist, but also the child,
the family.
the family, and often other specialists as well.
Absolutely. It takes a village to care for these children and help them reach their full potential.
You know, it's really inspiring to think about the progress that's been made in pediatric cardiology.
It is. All these advances in surgical techniques, imaging, and medical treatments have dramatically improved the outlook for these children.
It's amazing to see how far we've come in such a short amount of time.
It is.
What are some of the most exciting developments you've seen in your career?
One of the most exciting has been the development of minimally invasive surgical techniques.
Okay.
Procedures that used to require open heart surgery can now be done through tiny incisions.
Wow.
Less trauma, faster recovery.
That's fantastic.
We're also seeing incredible progress in artificial valves and heart assist devices.
Which offer?
New hope for those kids with the most complex and severe heart condition.
It's amazing what can be accomplished when brilliant minds come together.
It really is a testament to human ingenuity.
But we also have to acknowledge the emotional toll these conditions take,
Oh, absolutely.
not just on the children, but on their families as well.
It's not just the physical challenges, it's the emotional and psychological impact too.
The stress, the anxiety, the uncertainty.
All of it. It can be overwhelming.
So it's important to provide emotional support, connect families with resources.
Support groups.
Exactly, and address those fears and concerns openly and honestly.
And recognize that every family's journey is unique.
There's no one-size-fits-all approach.
It's about tailoring our care to the individual needs of each child and family.
Now, I know we touched on this a little bit before, but what about the role of genetics in these conditions?
Genetics.
Yeah, I know a lot of congenital heart defects have a genetic basis, but what about environmental factors?
That's a great question. It's an area of ongoing research.
Right.
We're still learning a lot about how prenatal exposures, maternal health, and other environmental influences can affect a baby's heart.
So the womb isn't a completely protected environment.
Unfortunately, no.
What happens during those 9 months can have a lasting impact.
It can, which is why prenatal care is so important, making healthy choices and avoiding those potential toxins whenever possible.
Now, this might be a question without a simple answer, but why do these heart defects happen in the first place?
That is the million-dollar question.
Right.
It's puzzled scientists and families for generations.
I can imagine.
In a lot of cases, the exact cause is still unknown. We know genetics plays a big role.
Some heart defects tend to run in families.
Exactly. And thanks to advances in genetic testing,
Right.
we're starting to pinpoint those specific genes that are linked to certain defects.
Which is incredibly valuable information.
It is, especially for families who are trying to understand their risk.
You make informed decisions
Yes,
about family planning,
exactly.
but it can't just be genetics, right?
Right. Environmental factors have to be part of the equation, too.
Things like exposure to certain medications during pregnancy or infectants.
Toxins,
Exactly.
those can also increase the risk.
So it's a complex interplay of nature and nurture.
It is. It's this intricate dance that researchers are working hard to unravel.
You know, something else we haven't really talked about is the long-term impact of these conditions on a person's adult life.
That's an important point. A lot of children with these conditions go on to live healthy, fulfilling lives.
That's good.
But some may face ongoing challenges. Some might need lifelong monitoring, medication to manage their condition.
Okay.
Others might have limitations in terms of physical activity or certain careers.
Right.
And some may experience psychological or social difficulties related to their heart condition.
So it's not just about surviving childhood, it's about thriving as an adult.
Exactly. And that's where ongoing support and resources are so crucial.
Helping them transition into adult care, addressing their concerns, and supporting them every step of the way.
It really is a lifelong journey for some,
It is. And it's incredible to see how resilient the human heart is.
both physically and metaphorically,
Exactly. It's an amazing organ.
capable of overcoming incredible challenges.
And it's a reminder that even in the face of these really tough obstacles,
Right.
there's always hope.
Always.
With all the advancements in medical care, research, and support services,
Yes,
the future for these children is brighter than ever.
it really is.
And that's a message worth spreading. We've covered so much in this part of our deep dive,
We have.
from the evolution of treatments to the ethics of fetal intervention.
It's been quite a journey.
It has. But before we wrap up and move on to the final part,
Okay.
what's one thing that's really resonated with you from our discussion?
What stands out to me is the importance of a holistic approach to care.
Meaning,
It's not just about addressing the physical aspects of the condition.
Right.
It's about emotional support, resources, empowering these families.
treating the whole child, not just the heart defect.
Exactly. Recognizing that behind every diagnosis, every surgery, every medication,
There's a child.
there's a child with dreams and a whole life ahead of them.
And it's our job to equip them and their families with the tools and support they need.
Beautifully said.
Are you ready to dive into the last part of our exploration?
Let's do it.
Welcome back to the Deep Dive. We've been on quite a journey exploring these acyanotic heart conditions in newborns.
We have. It's amazing how much there is to learn.
It is. And in this final part of our deep dive, I want to look ahead.
To the future?
Exactly. What are some of the most promising areas of research out there? You know, things that could change how we care for these babies in the years to come.
Well, one area that's really exciting is regenerative medicine.
Regenerative medicine?
Yeah. Imagine being able to repair damaged heart tissue using the body's own cells.
That sounds like science fiction. Is that even possible?
It's getting closer all the time. Scientists are already making some really cool strides.
How so?
They're using stem cells and other really innovative techniques to actually grow new heart tissue in the lab.
So instead of replacing a damaged valve with an artificial one,
Right.
we could actually regrow the patient's own valve.
Exactly. And think about the benefits.
Right.
Well, regenerated tissue wouldn't be rejected by the body.
Because it's their own cells.
Exactly. And it could grow and adapt as the child grows.
That's amazing. Are there any other advancements on the horizon that you're excited about?
Definitely. Personalized medicine is another area with a ton of potential.
We touched on that a little bit earlier with genetics.
Right. And the more we learn about those genetic influences,
Yeah.
the better we'll be able to develop these super targeted, effective treatments.
So it's about moving away from that one-size-fits-all model.
Exactly. It's about tailoring treatment to each child's unique genetic makeup.
That's incredible. But with all these advancements, I'm sure there are some ethical considerations that need to be addressed.
Oh, for sure. As we develop these new technologies and treatments,
Right.
we have to proceed very carefully and thoughtfully.
What kinds of ethical considerations are we talking about?
Well, for example, genetic testing is becoming more and more sophisticated,
Right.
but we have to be very mindful of privacy issues
Makes sense.
and make sure patients and families really understand what those tests can and can't tell us.
It's about using that information responsibly.
Exactly. And with things like fetal intervention,
Yeah.
we have to be incredibly careful about the potential risks to both the mother and the baby.
It's a balancing act, for sure.
It is. We have to balance medical expertise with ethical principles and the family's own values and beliefs.
It's a lot to consider.
It is. There are no easy answers, but they're questions we have to ask ourselves, especially as we push the boundaries of what's possible.
It's definitely a lot to think about, but it's also incredibly hopeful. It sounds like the future for these children is bright.
It is. It's a really exciting time to be working in this field.
I can imagine. Knowing you have the potential to make such a difference in these children's lives.
It's a privilege, for sure.
Well, as we wrap up this deep dive, I want to circle back to something you said earlier
Okay.
about the importance of that holistic approach to care.
Oh, yes, absolutely. That's so crucial.
We can't just focus on fixing the physical
Right,
problems.
we have to look at the whole picture.
The emotional, the psychological, the social needs of these children and their families,
It's about supporting them on their journey, empowering them with knowledge.
helping them thrive, not just survive.
Exactly. Recognizing that there's so much more than just their heart condition.
That they're individuals with dreams and aspirations and a whole future ahead of them.
And we're here to help them make the most of it.
Well, I think that's a perfect note to end on. We've explored the complexities of these acyanotic heart conditions, looked at the incredible advancements that are being made.
And even peeked into the future a little bit.
We have, and for our listeners out there, I hope this deep dive has sparked your curiosity.
It's a fascinating field, and there's so much more to learn.
So keep asking questions, seek out resources, and keep learning.
And most importantly, don't lose hope. The future is bright for these children.
Thank you for joining us on this deep dive into acyanotic heart conditions. Until next time, stay curious and keep exploring.